Hello, I'm Hugh Grantham. I'm Chair of Emergency Medicine Foundation, but I've been working in primary healthcare, emergency care and rural emergency care for most of my working life. My background in emergency medicine is one that's started actually in rural emergency medicine, and from there I was recruited to sort out the ambulance service in South Australia a long time ago, and was medical director of that for 18 years. I have academic appointments in universities currently with Curtin and QUT, and I've worked in frontline metropolitan emergency departments all during that time, so it's current with the frontline end. Now with EMF, I'm the chair of the board and board member, and managed to do that with a large, a well spread out group of EMF colleagues representing emergency medicine across Australia. I was lucky enough to be the medical director of the South Australian Ambulance Service for about 18 years. During that time we had the job of developing it from a service that was fairly rudimentary up to a service that was world class, with university graduates, masters, etc. supporting it. Now, in amongst that, obviously we became very aware of the difficulties of managing workloads, because the ambulance service is very much the place where the buck stops when everything else is shut. And so one of the particularly nice achievements was creating the extended care paramedics. And they've been on the ground for over 15 years now. And they run hospital avoidance by actually being able to take care directly to a patient who really shouldn't be taken to hospital. Classically, somebody with dementia and confusion and agitation in a residential care facility. If we can bring the repair of their wound or the draining of their abscess to them, this is just so much better for the patient, the family, and ultimately the whole system. So it works, has been working for a long time, and South Australia has been a role model in this area. Paramedics have been used in other states in a similar extended care fashion, but they've also been used as emergency stopgaps in health systems. In South Australia, we have had to support local hospitals when the local GP needs some time off. And I stress we'd only do that when there is no medical alternative. So it's very much not undercutting the medical officers, but at their invitation. And that's been the whole philosophy for the ambulance involvement in this stuff, is very much at medical invitation with medical cooperation, rather than acting in isolation. During my time in South Australia, I've seen regional and remote care as an issue fairly all the way through. Initially relatively well supplied with country doctors, now finding that harder and harder to get country doctors able to take on that lifestyle, because it is a lifestyle. So we have a number of communities now where they're struggling to keep practices going and keep hospitals covered, because regional and remote hospitals need the cover. Then beyond that, South Australia's got large areas where there is no town, there is no doctor, and we're really doing it with RFDS and local resources. And so we get involved in the intricacies of trying to extract somebody with an emergency from that distance. And there's been some stellar cases, actually. I'm thinking of one now who had a cardiac arrest halfway up the Unadata track, which for those of us who don't know is going to be about 3 hours north of Port Augusta. First response obviously was about 45 minutes and one flat tire away. That guy made it to hospital, had lots of rests on the way and walked out. And that, I think, is a testament to the joined up system. So we do pretty well in the rural area. I've been working in emergency medicine and in medical systems, particularly in South Australia, but obviously across the whole country for most of my working life. Currently, we have a focus on the front end of the hospital, the ambulance ramp, and everyone's measuring the delays on the ambulance ramp and trying to fix the problem by fixing things in emergency medicine and the emergency department to aid unloading. When you sit back and have a look from a decent distance, what you see is that the ambulance ramp is an indicator. It is a canary in the coal mine. And you then look at what's actually holding things up and where the extra load is coming from, and it's the whole of the health system that's a problem. So we've got a canary in a coal mine saying the coal mine is sick. We need to look at the whole mine. And through Emergency Medicine Foundation, we've actually been sponsoring, together with Queensland Government, some very thorough, proper research into this whole bed block and flow issue. Now, this research is just coming out now, and I think it'll be pivotal for decision making, not only for Queensland, but for the rest of the country, possibly internationally. But some of the obvious messages that are already there are that, yeah, you can shave minutes off an ED with an improved system, or a hospital avoidance system in an ambulance service will take a little bit of load off, but our hospitals in them, they need to have a 24-hour-a-day approach to treating people. So we're not waiting for a scan or a test so we can discharge somebody, because you can't do it at the weekend, and we don't want to bring in staff on weekend rates to run the scanner, because if you actually look at it, that's a false economy, because we're wasting far more by keeping the patient in hospital. So that's one area. It's the flow and the 24-hour-a-day focus of the hospital. But then you've got to look broader, and you've got to look at the whole of the health system. And here we have a problem, because the out-of-hospital system, the primary health care, is of course federally funded as opposed to the hospital system being state funded. So again, it's difficult getting them talking to each other. But in order to fix our current flow, we need to improve outputs of people who are ready to go home from hospital, improve the ability of community care for taking sicker patients earlier. And then at the other end, we need to improve the ability of primary health care, community care, to manage emergencies rather than default to hospitals. So there are lots of projects that are put up creating specific primary care clinics. But again, the numbers and productivity need to be looked at. And just as an observer who's been watching for a long time, I think probably rather than putting Band-Aids on, it's the general practice workforce that needs a lot of love and investment. It's the residential care facilities that need the same development, and so that they are capable of doing it. And I'm not critical of them, because if they are understaffed, under pressure, then they're not going to be in a good position to take sick people. But if we put the effort in to the whole of the health system, rather than focusing on the canary, we would get change. But it's going to be slow change. It's taken many, many years to get to this position, so it's going to take many years to come out of it. But what I see at the moment is I see a lot of short-term fixes focused at that front end, focused at the canary, which will produce small infinitesimal improvements when there are large slabs, and that's what this research is showing beautifully, because they've looked at 16 hospitals over 4 years, all the admissions, and then we've actually got researchers looking out into the availability of community support, general practice appointments, i.e. looking at the whole health system. And I honestly think that if we don't look at the whole health system, we're never going to be able to address this problem. And so my plea would be to get people to start thinking big picture and accepting it is a big problem, will take a long time, but avoiding the focus on this tiny canary. If we look at expensive manufacturing plants, there's no way that you would shut down your plant. You would run a night shift and not just a caretaker shift. So if we consider health as an industry where there is a need that's 24/7, then it doesn't make sense to shut down the industry overnight, over weekends. It should be fully staffed, fully equipped all the time. Currently, various areas of our health system are better covered over the downtimes than others, but as a general rule, you are more likely to find the care being left in charge of a junior staff member who may not be able to make the key decisions. They may not be able to make the decision to discharge without consultation all the way up the line. So the ideal world would be a staffing model where the seniors are on and available all the time. The equipment, the tests are available all the time, and so that we can actually adjust our patient care to patient needs. What I'm saying is not a popular thing to say, because everyone points to cost, but they also note that they did their time as juniors, and now that they're seniors, they've earned the right to sleep in bed at night. I understand that, and I do understand where it's coming from, but it wouldn't cut the mustard in another setting, in an industrial setting, a military setting, or any other large organisation. They would still make sure that they had senior decision makers and appropriate equipment available all the time. So that would make a huge, huge difference. And that includes, by the way, being able to have community services ready all the time. The problem of, well, it's Friday evening and you can't discharge the patient because, whereas we could have discharged the patient on Thursday. So it's not just the hospital, but the whole of the system needs to actually provide the whole of healthcare on a all-the-time basis. Preventative measures are obviously part of controlling and helping the whole health system, because if we can prevent somebody needing more care by stepping in earlier, then that's obviously going to take the load off. And the home of preventative care is the community, it's primary health care. So that needs to be supported, and we need good access to good GPs with good ability to actually turn off some of that tap. Unfortunately, as we age and our life expectancy goes up and our healthcare expectancy goes up, preventative care is not going to be the answer to everything, but it certainly does need some work in that space. Then we've got the reform of the whole of health, and the whole of health is a really wicked problem, in the true sense of a wicked problem. It requires a will to change. It requires a joined-up system, and I question the wisdom of splitting our health between federal and state because it's difficult to keep the same message. It requires some cultural change. So one of the barriers is, well, we've always done it this way. And it will require some significant investment. What we're asking for will be more expensive than running a part-time service. So there is a lot of wishes here which are probably politically quite difficult to achieve, culturally quite difficult to achieve, but if we don't achieve, then we are looking at a continual downward spiral, which those of us who've been in this space for a while have been sitting and watching and trying to slow down for the last 10, 15 years at least.